my name's Ellie Jo. I'm subspecialising in congenital heart disease at the LGI, and I've been asked to talk about the local management of the low and moderate risk patient. So there are multiple different risk stratification models for calculating risk for cardiac patients, including Sahara and CARPREG, but both the European and the American guidelines both agree that the modified two classifications are the most reliable, and therefore that's what I've focused on here. So those that are low risk from the class 1 and class 2. These include patients with mild valve disease or simple lesions or arrhythmias such as supraventricular arrhythmias or isolated ectopics. It does also include repaired tetralogy of Fallot, but to note that this is only if the repair is of good quality. And Turner's syndrome, the patients must have a normal aorta, but to note that in these patients, to be normal, the measurement is actually indexed for height due to their short stature, and therefore not to be reassured by an sort of an absolute diameter, which is normally within normal limits. Those that are deemed to be moderate risk are those in the modified 2 class 2 to 3, and these include mild left ventricular systolic dysfunction, hypertrophic cardiomyopathy, valve disease that is neither low risk or high risk, Marfan's and hereditary aortopathies with the normal aorta, repaired coarctation of the aorta, and atrioventricular septal defects. Now, the European guidelines that Dr. English also mentioned have this very useful table that includes both the maternal cardiac event rate and also documented advice on the location for both follow-up and delivery for these patients. Of note, the maternal cardiac event rate includes worsening symptoms such as breathlessness and palpitations, which, as we've just mentioned, can also be physiological during pregnancy, as well as including changes to medications, new medications, and the more significant events such as prolonged arrhythmias, reduction in systolic function, and ischemic events. As you can see, those that are low risk can be followed up locally during their pregnancy and also delivered locally. And in the moderate group, the European guidelines do recommend referral to a tertiary centre, but as we will discuss, this is on a sort of individual case-by-case approach, and some patients in the moderate group can be safely managed locally following a review by ourselves. Now, the majority of the guidelines do focus more on the more complex cardiac disease and those at high risk during pregnancy, but it is noted obviously that for all patients that transthoracic echocardiography is the preferred imaging during pregnancy, and this should be performed periodically during outpatient follow-up, and also if there are any unexplained or new cardiovascular signs or symptoms during pregnancy. All of our patients with congenital heart disease are offered a fetal echo, and in the European guidelines, this should be between the 19th and the 22nd week gestation. And they quote that 45% of malformations would be identified during this screening, but this is something we will hear more about during the later talks. The delivery plans should always include details of any induction plans, the management during labour, and also surveillance during delivery and postpartum. For low-risk patients, a vaginal delivery is preferred, and the reasons they give for this is the reduced risk of hemorrhagic complications and also the lower risk of infection and VTE. And they do advise that we should consider inducing all women with any cardiac disease at 40 weeks gestation. The American guidelines actually are almost identical in terms of their advice for low-risk patients, with the only real difference being they advise considering induction a week earlier at 39 weeks gestation. Both the European and the American guidelines agree that antibiotic prophylaxis for infective endocarditis is not recommended during either vaginal or caesarean delivery in this patient group. Now, locally, the first point of contact is either a local midwife, sometimes a GP, or our ACHD specialist nurses. No matter who the first point of contact is, the preliminary screening would be the same, obviously inquiring as to the LMP, ensuring the pregnancy is confirmed, and whether they wish to continue with the pregnancy. Through review of their clinic letters, there should be documentation as to whether they've had any pre-pregnancy counselling and whether there are any plans already in place for managing a pregnancy, and to make sure that the patient is aware if there are any increased risks if they do continue. As with all patients, an estimated delivery date will be calculated. They should be booked with a local midwife and a dating scan organised locally. We obviously need to make sure that everyone who needs to know is aware of this pregnancy, both locally and in the LGI, and all the patients have the contact details for our ACHD specialist nurses, which is always documented at the top of our headed clinic letters as well. So the immediate actions following a confirmed pregnancy, the consultants, both obstetric and cardiology, should be informed. As we've discussed, obviously we then risk assess whether these will be high, medium or low risk pregnancies going forward. The majority of our patients to low risk and some of the moderate are actually unlikely to be on any cardiac medications, but if this is the case, please don't stop them without prior discussion with ourselves. It's important to consider both the risks and benefits of continuing any medications. With all pregnancies, we do advise folic acid with an increased dose if they are also on warfarin, and obviously we advise against refraining from smoking, alcohol or the use of recreational drugs while pregnant. Slightly differently in terms of gestation to the European guidelines, we tend to organise our fetal echoes between 18 and 20 weeks, and these are arranged either by the midwife in the community or the obstetrician if they're under obstetric-led care. Depending on the risk assessment in terms of their risk of pregnancy, this will affect when we first need to see them in clinic. So our clinics occur every Monday afternoon in outpatients in the LGI. There are two clinics that run side by side, one for congenital patients and one for acquired cardiology patients. And both clinics are attended by both an obstetric and an anaesthetic consultant, so that patients are reviewed by all three specialties simultaneously during their appointment. Those that are low risk, we see once at their 20-week gestation, which we aim to coincide with the day of their fetal scan. But those at a moderate risk, we do like to see a bit sooner, usually at 12 to 14 weeks. In general, these patients often continue local obstetric care, as well as being seen in the joint cardio-obstetric clinic. And the outcomes of all their clinics are documented on their clinic letters, which are on EPRO and also PPM. And patients who attend clinic who aren't local to Leeds, a note will be written in their paper notes as well to summarise the consultation, as well as trying to copy letters to all the local obstetricians for their records as well. As well as discussing their cardiac conditions, we often also discuss lifestyle advice. Many patients can and should continue regular exercise throughout their pregnancy, as well as remaining hydrated. The VTE risk is no different to that for the general population, and as well with employment, as long as they've had their usual occupational health risk assessment, there is no cardiac reason why they can't continue to work during their pregnancy. Some of our patients at a lower risk will have pacemakers in situ. Obviously, we need to review the indication as why they were implanted in the first place. But if the heart is structurally normal, it's often due to congenital complete heart block. As we've also already discussed with all patients, an echocardiogram is always useful, and in this case it can assess the systolic function to ensure there's been no evidence of pacing induced cardiomyopathy. But on the whole, these patients are generally low risk in their pregnancies. We can interrogate the pacemakers. We need to ensure that the lead function is good, the battery life is adequate, and we can also then see if there's been any recent arrhythmias, and most importantly, determine whether they are pacing dependent. If the initial indication for implantation was sick sinus syndrome, the lower rate limit of the pacemaker should be increased during pregnancy to parallel the physiological heart rate increase that normally occurs during pregnancy. And again, this inability to raise heart rate is important during delivery, as the heart rate may not actually increase during labour. This is something that can be adjusted by just contacting the local pacing team, who can come and adjust the settings on the pacemaker. But if there is a delay in that occurring, or something needs performing more urgently, you can actually tap over the generator box at the rate that you want it to pace. And I've also been reliably informed you can jiggle the patient to have the same effect. Now, if there are no underlying P waves and the patient is paced through their atria, it's also important to be aware that there's no heart rate response to hypertension. So especially obviously in delivery, in the event of a significant bleed, often it's a raise in heart rate that starts to alert you that something may have occurred, and this response obviously will be absent in this patient cohort. In a sort of planned spontaneous vaginal delivery, there would be no need to inform the pacing team otherwise during the delivery. Obviously, if you go to theatre and you're using diathermy, ideally you should use bipolar, ensure the ground electrode is distant from the pacemaker, and continuous cardiac monitoring should be in place in order to assess for any evidence of inhibition of the pacemaker. I've not included ICDs in this talk, as obviously these patients are very unlikely to be low risk or even moderate risk, but just in case they did arrive in a local DGH unannounced in labour, to be reassured that actually recent studies have shown that there's no arrhythmias or ICD shocks occurring during delivery. But if you were in a position where there was a patient having inappropriate shocks from their device, and there's no pacing technician available, a magnet can be used to inhibit these sort of tachycardia sort of therapies, such as shocks and ATP. And these magnets are usually located in the coronary care units and the emergency departments of each hospital. The magnet should be placed over the device continuously, not to be removed, because once it's removed, then it goes back to original settings. And although it will inhibit shocks, it won't affect the bradycardic pacing if it is required, but it will go back to sort of asynchronous pacing, so will no longer sense. So apart from pacemakers, otherwise intrapartum care, very reassuringly, that if the patient is clinically stable, that low-risk patients should actually anticipate a completely normal labour and delivery. You can prescribe analgesia as per patient preference, and the only consideration really would be to avoid terbutaline if the patient has a history of arrhythmias. See, postpartum, you should be considering contraception. The usual contraindications for combined oral contraceptives are the same as for the general population. So obviously not advised if there's previous history of thrombosis, deranged hepatic function. But for our cohort, we don't recommend them if there is cyanotic congenital heart disease. And also it's obviously not a particularly reliable form of contraception if we know the patients have poor compliance to medications. And this is obviously the same for progesterone-only pill. But on the whole, progesterone only contraception is very suitable for all patients. If more Mirena and copper coil, while historically these were avoided due to risk of bacteremia and menorrhagia, it's now acceptable for congenital patients, and on balance, the Mirena is probably a more preferable option. If patients are going for caesarean, Obviously, we do sometimes discuss having sterilisation at the same time. And finally, obviously, vasectomy isn't actually addressing the risk of pregnancy in our patients. And also just to note that some of our patients do actually have a reduced life expectancy, and therefore, there is the chance that husbands and partners may outlive the patient, and wish to sort of father more children in the future. So obviously, just to summarise, that patients at low risk and some of the moderate risk patients are completely safe to deliver locally. There are obviously benefits for local delivery, most notably convenience for the patient, not having to travel a significant distance, and being obviously then, as a result, far away from other family members, especially at the moment with the reduced visiting restrictions. If there is an emergency and they have to go to their local department, the team will already be familiar with them. And this also, by delivering locally, can reduce the pressure on the specialist centres. If we deliver in Leeds, we often do this by an induction, but if we're delivering locally, this will reduce the requirements for induction, as we can allow them to go into spontaneous labour, and hopefully then also reduce the need for any assistance during delivery. And obviously confidence breeds confidence, so by having these patients delivering in local centres, hopefully then the more patients you're involved with, the more confident you'll be in managing them more in the future, going forward. And I think finally, just important that all members of the team are in agreement, so not only in the tertiary centres but also in the local hospitals, both cardiologists, obstetricians and anaesthetists, and obviously, as Dr. English mentioned, communication is key, either by phone or through clinic letters, to ensure that everyone is in agreement of the plan going forward, to hopefully avoid changes of direction last minute, which understandably can then cause some distress to the patient. Thank you very much.